Good afternoon. Thank you, ladies and gentlemen, for inviting me to this wonderful initiative of having a global platform to discuss colorectal cancer and various aspects of this disease. What I want to concentrate on during the next 20 minutes is patients with colorectal cancer liver metastasis, so the population of patients who actually present with metastatic disseminated disease, but the disease is located solely within liver. And what we can do to increase the chances for cure in this patient population? As you know, in the majority of solid tumors, once we have patients with disseminated disease, we assume that they have no chances for cure, but this is not the case in patients with colorectal cancer. Approximately 50% of patients with colorectal cancer, which is disseminated, present with liver-only metastasis, and they die with liver-only metastatic disease, demonstrating that the disease in disseminated state can be disseminated solely within liver for the whole time the patients are treated with palliative setting. And therefore, this presents a unique opportunity to consider curative approaches for this patient's population. The assessment and actually the idea that we can consider curing patients with liver-only metastasis came from some large registries like a UK registry, which collected patients' data from 1998 to 2004 of all patients with colorectal cancer diagnosed in UK. As you see, it's almost 115,000 patients. And when they started to look at the registry and the outcomes of patients, they noted a very interesting signal. As you see, the outcomes of patients with the colorectal liver metastasis is approximately 50% of patients who die due to the disease, which is typically what we see in colorectal cancer globally, where approximately 50% of patients can be cured from this disease. Patients with stage 3 disease, so the patients with lymph node involvement, the prognosis is a bit worse. It's like 40% of patients surviving 5 years. And with stage 4 disease, so patients with disseminated disease treated solely systematically with the palliative systemic treatment, their outcomes, it was, of course, 20 years ago, but their outcomes were really dismal with 5-year survival rate below 10%. And this registry actually showed that there was a small patients population. So it was like 3,000 patients with liver metastasis who underwent resection of liver metastasis, something that was totally not a standard approach to this patient's population at that time. But this study actually, this registry actually showed that the outcomes of patients with liver-only metastasis who underwent radical surgical treatment, the outcomes were similar to what was seen with patients who never presented with disseminated disease. And this actually showed that resection of liver metastasis can be associated with significant improvement of patient outcomes, similar to patients who were never diagnosed with disseminated disease. So, what do we know about metastasectomy in this patient population? We know that the cure can be achieved in approximately 12 to 36% of patients with metastatic colorectal cancer. That after 10 years without recurrence, we can think about being able to confirm the cure. And even patients who recur with the disseminated disease, who once underwent liver surgery and were treated with surgical resection of liver mets, even if they recur with an operational disease, they live longer than patients treated solely with chemotherapy. And the difference was approximately 4 years. So there is more and more data showing that resection of liver metastasis in patients who have only liver-limited disease can significantly improve patient outcomes, that we should try to increase the number of patients who undergo liver surgery, and we should think about increasing the chance for surgery by applying neoadjuvant chemotherapy. And this is what can be achieved in the case of patients with initially unresectable liver metastasis. As you see, compared to patients with resectable liver metastasis, so patients who once are diagnosed with liver mets can be sent directly to surgeons to undergo surgery, who have 10 years survival rate approximately 30%. Patients with initially unresectable disease, who usually are treated as palliative patients with standard palliative chemotherapy or chemotherapy combined with biologic agents, who with only systemic treatment have no chances of 10 years survival. Once we convert the initially unresectable liver lesions to resectable metastasis, we can achieve 20% of long-term survival, which actually, after 10 years, may mean that the patients are indeed cured. So, how to use neoadjuvant chemotherapy in our patients? Is it safe? Should we go very intensively? Should we administer a lot of cycles of chemotherapy? The answer is no. Actually, as you see here, without chemotherapy, the risk of surgical complications seems to be the lowest. But of course, many patients with initially unresectable disease with no chemotherapy will never convert to resectable metastasis. So we should give chemotherapy. But the less numbers of chemotherapy cycles we give, the less complications we will have. And this is the difference between 5 or less cycles or more than 6 cycles of chemotherapy. Do we have any information on how to optimally use available cancer treatments for colorectal cancer with liver metastasis? Is there any optimal neoadjuvant strategy? So first, what we know is that when we decide to go for converting unresectable lesions into resectable, we should put everything we can on the first line. So as you see, the number of chemotherapy lines and the probability of resection diminishes with the further lines of treatment. So either we achieve resectability during first line of treatment, or we will end up with very low number of patients who will be able to undergo liver surgery. So first line should use the most active approaches. So what do we know about most active systemic approaches? So we know that using chemotherapy combined with various targeted agents, either anti-EGFR antibodies or anti-VEGF antibodies, we continuously increase the chance for response. So we increase the chance of tumor shrinkage. We increase the chance of converting initially unresectable lesions into resectable lesions. So we know that the use of biological agents in patients who are candidates for neoadjuvant treatment is crucial because this is the way to improve the chance of converting the lesions into resectable ones. We also know that the more active treatment, especially with the biologic agents, the higher the chance of R0 resection. So microscopically radical resection is increased with the addition of biologic agents. So here we see that we should concentrate on using doublet chemotherapies with biologic agents, because as you probably know, a recent paper published in JAMA Oncology demonstrated that doublets plus biologic agents is no worse than triplets with biologic agents, which of course are much more toxic. So going for doublets with biologic agents, so anti-MGFR antibodies in patients without KRAS, NRAS, BRAF mutations, or bevacizumab in patients who have some of the genes mutated, is the optimal way forward to increase the chance of converting initially unresectable lesions into resectable ones. So the number of various papers showing every time the same situation. The more aggressive treatment, the more active treatment. In the case of initially unresectable liver metastases, the higher chance of objective response, the higher chance of surgery, the higher chance of radical, microscopically radical surgery. So we also know that the number of cycles is not only associated with the risk of surgical complications, but it's also associated with the outcomes. So the more cycles we give before surgery, the poorer the patient outcome is. So it means, again, that we have to concentrate on the first 12, 15 weeks of treatment. We should choose the most active strategy, and we should opt for aggressive initial treatment to convert the unresectable lesions into resectable in the shortest possible time. So the optimal treatment should be the most effective, which allows us to perform the neoadjuvant chemotherapy with benefit within the shortest time. And of course, we always have to look at the safety of the regimen. When should we go for surgery after neoadjuvant treatment? It seems that we should not perform surgery within the first month after completing the neoadjuvant chemotherapy. So the patients should undergo surgery after the week 5th and later, knowing that, of course, the risk of surgical complications decreases with the longer time. But again, we have the risk of disease reactivation and disease progression. So just keep in mind that we have to give our patient 1 month since completing the adjuvant chemotherapy to surgery. We also know that with the novel approaches, novel agents, better genomic analysis, we increase the response rate and we also increase the resection rate. But in real world situation, the benefit of increased response is not always translated into the benefit of resection. So it means that we have novel agents, novel therapies, but we do not consider many of our patients who probably can be candidates for liver surgery. We are not considering them as candidates for liver surgery. Therefore, looking at the data, we see that even though we have more and more active regimens, we do not treat surgically the expected rate of patients. And in Polish registry, where we see with novel biological regimens, chemotherapy plus biological agents, overall response rate in well-selected patients population beyond 70%, we should see at least 20% of patients who undergo metastasectomy. We see less than 10%, but in the real world data, they're extremely, well, let's say, ideal world, we should see in patients with liver-only metastases who achieve 70% of objective response rate, the metastasectomy rate, as based on clinical trials that actually aim to evaluate the impact of neoadjuvant treatment, we should see more than 50% of patients who undergo metastasectomy with liver-only disease. So 10% or even 20% in real-world situation is still not too much. And we should do everything possible to increase the percentage of patients undergoing metastasectomy. So there is not only the question what to use in terms of which regimens, which drugs, how to combine biological agents with chemotherapy. There is also a question how to find the proper patients for this kind of treatment, for neoadjuvant chemotherapy and then surgery. There are 4 clinical trials that actually reported the outcomes of patients with liver-only metastases. And what we've seen there, it was that if you use multidisciplinary teams with liver surgery specialists, you can identify more patients who are candidates for liver resection. Even the best practiced oncologist, medical oncologist, has not sufficient knowledge regarding who is a candidate for liver surgery, who have liver lesions which can become resectable upon response to systemic treatment. So in order not to miss the patients, we have to collaborate with liver surgery specialists. Because as you see here in the Selim and Pocher studies, those well-selected patients, almost 60% of patients underwent liver surgery with liver-only disease. So the international recommendations clearly show that surgery is the best option we can offer our patients. All other local regional treatments or systemic treatments are less, potentially less effective, and the level of evidence is lower. We should do everything possible to perform surgery on patients with liver-only disease. So, whom to qualify? So before we can decide who can qualify to this approach, we have to perform adequate staging. We have to perform tumor biology determination. So RAS, BRAF status, microsatellite instability, DPYD, in order to know that we should safely administer fluorochlorimidates. We should also perform patient general health assessment in order not to qualify to this kind of aggressive treatments. Patients were not candidates for large surgical approaches. Of course, multidisciplinary team is the clue. Resectability assessment, there is no strict standard criteria. There is the most important criteria is the future liver remnant. So after surgical treatment, 20% of liver should be maintained to maintain proper liver function. If the surgery that is planned, resection of all metastases, will end up with less than 20% of intact liver, this patient cannot cannot go straight to surgery. We have to think about other approaches, two-step surgery or more chemotherapy to diminish the sizes, or the lesion sizes. What is really critical and what is needed and what is the most challenging issue is experienced team of liver surgeons who have extremely huge experience on treating patients with liver diseases, including liver metastases. How not to overlook potential candidates. So we have to perform careful assessment of the number and distribution of metastases. We should verify equivocal lesions. We should reassess patients with exceptional response, and we should consult patients in highly experienced hepatobiliary surgery centers. So for whom is the liver mets resection? For patients with single organ involvement. We are not considering liver metastasis resection in patients who have also, for example, lung metastasis. The number of metastases, when we talk about resection, cannot be very large. Surgeons have to count the metastases and excise, resect each metastasis one by one. The size of the biggest met should be below 5 centimeters. Optimally, it's patients with wild-type KRAS and RAS-BRAF. Of course, patients with mutated genes should undergo proper systemic treatment, and once they respond, they can undergo surgery. Separation from primary lesion. It means that the liver metastasis should be metastasis and not direct infiltration by primary lesion. A primary lesion with without lymph node involvement and CEA below 200 nanogram per mils. This is factors that the more factors we have, the higher the chance of optimal liver surgery. But of course, every single parameter in here does not exclude the patient to undergo surgery, except for single organ involvement. So if we have patients with metachronic dissemination, when we want to go for primary surgery, we have to have at least 12 months from the resection of a primary lesion. Otherwise, we have to consider giving the patient chemotherapy to be able to resect the lesions and to check if the disease is indeed liver only. So what do we have developed in Poland? It's a Polish consultation platform for patients with liver-only metastases. It's called RACER platform, which actually allows us, medical oncologists from every single site in Poland can use this online platform to send DICOM images of their patients along with clinical data to the central high volume site of liver surgeries. It's one of the biggest liver surgery sites in Europe. There is like 40 surgeons only treating patients with liver diseases. And within one day, the medical oncologist receives response whether or not the patient is a candidate for liver surgery up front or have to undergo neoadjuvant treatment or will never be a candidate for liver surgery. Once the medical oncologist gets the data, he starts the treatment or refers the patients personally to the liver surgery side, and then the patient undergoes local assessment by the surgeons and is then qualified to surgery or not. If the patient has to undergo neoadjuvant chemotherapy, the medical oncologist send again the data after 5 cycles of neoadjuvant chemotherapy, and then the team decides whether or not the patient is ready for surgery. So there's a lot of different options regarding surgical approach to liver only colorectal cancer. There is some 2-step, 1-step approaches combining surgery with ablation, with intra-arterial chemotherapy, or with SBRT. But what we also know is that the progress in the realm of surgical treatment of colorectal patients with liver metastases is progressing very rapidly. We know that many patients, even those with complete imaging response, still have detectable lesions upon pathological assessment. Even patients with a complete response have lesions that contain live tumor cells. But what we know, and this is what really changes the situations of many patients with unresectable metastases, is that unresectable colorectal cancer liver metastases become an indication for liver transplantation. We know that biliary tract cancer, hepatic cancer, NETs, hemangioendothelioma epithelioides, these were standard long-lasting indications for liver transplantations. But now we have data showing that we can also consider liver transplantation in patients with unresectable colorectal liver metastases. And this data is coming. This data is not very old, but the more and more information regarding safety, tolerability, and long-term outcomes of patients with liver-only colorectal cancer metastases after transplantation come to light, we see that this is an option we should consider in many of our patients. So patients with very good response to systemic treatment, even if they had unresectable liver metastases or very numerous metastases that cannot be resected one by one, those patients benefit from liver transplantation. And it seems that we may significantly improve outcomes of colorectal cancer patients with liver-only disease with unresectable liver metastases by performing liver transplantation. So now we have started in Poland a project using our platform to decide whether or not the patients are candidates for liver surgery. But if they are not candidates because the lesions are unresectable because of the numbers or the location, they are still considered candidates, potential candidates for liver transplantation. But what we know is that either patients with liver mets who have very indolent disease or liver mets after adjuvant treatment, and the patients are observed for 1 year and there's no progression of the disease beyond the liver, they can go for transplantation. But also patients after neoadjuvant treatment who have at least response that lasts for 6 months, those patients are also candidates for liver transplantation. So now we have another option for our patients, taken into consideration that once we achieve the response has to last at least 6 months. But still, those patients cannot undergo standard surgery because of the number of the location of the metastatic lesions, but they still are candidates for transplantation, which possibly may lead also to the cure. So, whom to qualify for liver transplantation? Patients without primary tumor, patients with at least 12 months of follow-up for unresectable metastases, patients without extrahepatic metastases, patients after 6 cycles of chemotherapy with at least disease stabilization that lasts for 6 months, patients without BRAF V600E mutation, patients without microsatellite instability. This genomic issue is because of the data we have. Patients without large basal involvement, patients with relatively low CEA, and with good performance status. So keep in mind that working in a multidisciplinary team with experienced liver surgeons, not general surgeons, not oncological surgeons, but experienced liver surgeons, we can significantly improve the outcomes of our patients with colorectal cancer and liver-only metastases, because we can define whether or not to go for surgery up front, whether or not the lesions are initially unresectable, but we can go for neoadjuvant chemotherapy and allow resection of the lesions, or whether the patients are indeed candidates for a unique novel approach with this liver transplantation. Thank you for your attention.
Thank you. Thank you very much, Professor Wysocki, for your excellent presentation. Actually, you covered a very relevant and modern topic, providing valuable insights into improving treatment outcomes for colorectal cancer with liver metastases. Thank you very much. So I encourage the audience not to hesitate to ask any questions or share comments while we still have time. Your participation will make our discussion even more productive. If there is any question? While this, Professor Wysocki, I would like to ask one question to you. In cases where colorectal cancer is diagnosed with initially resectable metastases, when it's solitary and easy accessible for surgery, do you believe it's better to proceed with surgery first or start with systemic chemotherapy? It's very modern question in our country in Armenia. What factors should guide this decision in clinical practice? Thank you.
Well, of course, the extent of the disease within the liver, if it's large metastasis, if it's solitary, if it's large, and we see that the surgery can be challenging, I would consider going for chemotherapy and then considering how to approach the patient. But many times we see patients with primary lesion and multiple liver metastases. So I believe that those patients should undergo chemotherapy upfront, because what we know is that the primary lesion untouched is rarely a problem with patients undergoing long-term palliative systemic treatment. So the patients will never or almost never have problems with the primary lesions and some disturbances in the intestine function. So, but if I see small liver lesion and the patient is a candidate for synchronous resection of liver lesion and primary lesion, I would go for this and then administer adjuvant chemotherapy, because it may just, complete the process of treatment and we can end up with the patient who is cured.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.